Good afternoon. Thank you for joining our webinar today. My name is Sean Coffey, and I work at the National Center on Caregiving at Family Caregiver Alliance. I'll give a brief overview of Family Caregiver Alliance, and then we'll jump right into hear about Texas and their experiences implementing a caregiver assessment. FCA is located in San Francisco, and we have worked for over 30 years to improve the quality of life for family caregivers through direct services, research, public awareness, and advocacy. Our local program, the Bay Area Resource Center, is one of 11 caregiver resource centers located throughout California. Our social workers meet with family caregivers in their homes, conduct assessments, and connect the caregivers with resources, including a respite grant that we administer. FCA also operates the National Center on Caregiving, which is funded by grants from the U.S. Administration on Aging to research policies, programming, and legislation that affects family caregivers. As part of this work, FCA partners with ARCH National Respite Network and Resource Center to administer the TA Center for Caregiver Programs and Lifespan Respite. Before we get started, I do want to point out that because of the large number of participants, your phones have been muted and will remain muted for the entire presentation. If you have questions or comments, please type them into the box on your toolbar. We have scheduled time at the end of the webinar for questions. Also, an archive of the webinar and the PowerPoint slides will be posted to FCA's website by Friday. With that, I want to welcome everybody to the call. We have over 40 states represented today. We wanted to learn more about Texas's experience because we know many states have caregiver assessments, and we've heard a lot of interest across all settings in the assessment tools and processes. So we wanted to learn more about Texas's experience with legislation mandating the creation of a uniform assessment tool to be used statewide in their Title III programs, as well as their caregiver status identification in their Medicaid HCBS programs. We are joined today by several folks from DADS who will present on their respective areas. Jeffrey Sider is the Chief of Staff for Access and Intake at DADS, and we are especially indebted to him for helping put this webinar together. Patricia Bordy is the Manager for Special Projects at DADS and will discuss the development of the Caregiver Assessment Tool. Lisa Akers-Owen is the Manager of Community Service, Policy and Curriculum Development and will discuss the implementation of the Caregiver Status Questionnaire. Sue Fielder is the Manager of Contract Accountability and Oversight and will present on the implementation of the Caregiver Assessment within the AAAs. With that, I'm going to turn it over to Jeffrey, who's going to start us out by explaining the legislative history behind the assessment. Thank you, Jeffrey.
Thank you, Sean. Next slide, please. And next slide. One more. Thank you. Good morning or good afternoon from wherever you may be joining us. On behalf of today's panel, I want to thank you for joining us. I also want to thank Kathy Kelly for inviting us to speak and Sean Coffey for his technical assistance. It's our pleasure to provide webinar participants with information on what we in Texas are attempting to do with regard to our caregiver assessments. In today's presentation, we will provide you with a brief legislative history, an overview of our development and implementation processes. You'll learn how the tools are being used in our functional eligibility determination process for Medicaid programs at DADS, and how the tools are being used by area agencies on aging. In those presentations, you will learn what have been our hurdles we have had to overcome and what challenges still lay before us, as well as things we wish we had known then that we know now. And finally, we'll give you an idea of what the future has in store for this program. Now on to the history lesson. Next slide, please. So what led us to where we are today? Next slide. In 2009, three very important documents were released. The Legislative Budget Board recommendations released in January 2009 and subsequent passage of Senate Bill 271 later that spring were further supported by a report published by DADS in October of 2009 entitled Informal Care in Texas, Aging Family Caregivers and Their Need for Services and Support. Utilizing the results of stakeholder focus groups held in 2004, the report specifically focused on the aging Texas population of family caregivers and described the role these individuals play in ensuring the individuals under their care are able to remain in their homes. The report concludes that informal or family caregivers, whether a grandparent caring for a grandchild or someone caring for an older family member or friend, have identifiable needs for services and support. When these needs are met, the caregiver is able to continue to provide informal care for a longer period of time. The longer that care is provided by informal caregivers, the less impact there is on public funds and public programs for formal care through both community-based and institutionally based settings. Stakeholders and experts agree that budgetary constraints, along with the rising cost of providing formal care and services to individuals, could be addressed by further recognition of the value of informal caregivers and the need for supportive services so they can and will continue to provide quality care for their loved ones in their community. Next slide, please. 3 common elements form the fabric of these 3 documents. 1, informal caregivers are the backbone of the long-term care system. 2, identifying and meeting the needs of millions of caregivers will be a challenge, but doing so often determines whether the person needing care can remain at home or if they must enter an institutional care setting. And 3, a uniform tool could be used to tailor services and supports to informal caregivers. Next slide, please. Senate Bill 271 was passed during the 81st legislature in 2009 and incorporates the 2009 recommendations released by the LBB in January relating to strengthening informal caregiver support services as it relates to the appointment of, and it also relates to the appointment of a successor guardian. For this presentation, we focus only on Section 1 relating to caregiver assessments. For this initiative, the author of this bill was Senator Chris Harris of Arlington, and a number of stakeholders actually worked with the original bill developers on this piece of legislation, and that was House Bill 3367 by Representative Patrick Rose and Senate Bill 1766 by Kirk Watson. The stakeholders that backed those initial bills included the Lone Star chapter of the National Multiple Sclerosis Society, as well as a Texas Public Affairs agency, Arnold Public Affairs, among others. Those 2 bills, although they did not pass, the sections of those bills relating to caregiver assessments were then incorporated into Senate Bill 271, which I said was authored by Senator Chris Harris. In general, Senate Bill 271 directs dads to raise public awareness about caregiving and available support services. It also directs dads to implement a caregiver status form, what we call the Caregiver Status Questionnaire, into the existing Medicaid functional eligibility determination process. Develop a standard caregiver assessment, which we refer to as the Caregiver Assessment Questionnaire, or CAQ, and protocol for caregivers accessing services through area agencies on aging, and summarize our data analysis in a report to the legislature. Next slide, please. In late summer of 2009, a work group was pulled together from the Access and Intake Division and several of our sections and units, including Community Services and Program Operations, Area Agencies on Aging section, and our Special Projects unit. We also included ad hoc members to this process of our Community Services Regional Directors, who would be implementing the Caregiver Status Questionnaire in the Community Services regions, as well as AAA directors who would be responsible for implementing the caregiver assessment. Many of the people that were included on this work, in this work group, you will be hearing from later today. Next slide, please. As you can see, implementation took 1 year for DADS to complete. During this time, we worked with Community Services Regional Directors and AAA Directors on our tool development. We piloted these tools in January and February of 2010. worked with our ID department on system enhancements throughout the spring, and developed the implementation procedures later that summer. The tools have been in place since August of 2010. Next slide, please. Now I will turn the microphone over to Patricia Bordy, our Special Projects Unit Manager, who will describe to you our tool development process. Patricia.
Thank you, Jeffrey. Next slide, please. The tools that we developed were guided mainly by Senate Bill 271, as Jeffrey said, and with the overarching commitment to the functionality of the tool. There were four things that we looked at when we were developing the tool. First, we wanted it to be able to evaluate the needs of the informal caregivers. By informal caregivers, we mean unpaid family, friends, neighbors providing assistance to care recipients. We also wanted to use these tools, both tools, to better measure the effectiveness of caregivers, really including their self-reported assessment of their skills, the impact of their caregiving on the care recipient, and their understanding of the tasks, of the disease condition of the recipient, and of the stress that their caregiving may have caused them. We also wanted to improve existing programs and develop new services, as indicated in Senate Bill 271. We wanted to provide a more targeted approach to providing caregiver services based on the profile characteristics we gained from these assessments and questionnaire, and also based on the geographic location and the needs of those specific caregivers across Texas. The last thing we wanted to look at and use the tools for was to determine the effect of informal caregiving on employment, as specifically required under Senate Bill 271. Next slide, please. Next slide, please. The work group was charged to develop two separate caregiver tools. One is known as the Caregiver Status Questionnaire. This was the tool that was to be used to identify the caregivers and their needs. We called this the profile tool. It would be implemented in 11 community service regions, and this tool, as I said, was used to identify informal caregivers for the referral purposes and to develop a profile of the caregivers across Texas. Who are the caregivers that are living in South Texas? Who are the caregivers in Central Texas, North, East? We wanted a clearer picture so that we could better design programs to meet the needs of these caregivers. The second tool that was to be designed was the Caregiver Assessment Questionnaire. This would be used and implemented at the 28 AAAs across Texas and would be utilized as a needs assessment to gather additional data. The Caregiver Assessment Questionnaire includes all of the elements of the Caregiver Status Questionnaire, but also additional information about tasks performed by the caregivers, about education, training, and skill development needs identified by the caregivers, and also additional information about stress that they may be experiencing, and more information about priority categories as requested by the AAAs. Sue Fielder will go into that a little bit more later on in the discussion. Next slide, please. In the initial development phase of the tools, I conducted extensive research and a review of existing tools. The first thing that we looked at was the tools available at the Texas Area Agencies on Aging. Some area agencies on aging were already conducting caregiver assessments, but there was no uniform, consistent tool being used statewide. So that's where we started. The second thing we looked at were existing tools for a number of other resources. The first one were National Caregiver Informational Clearinghouses, like the Agency for Healthcare Research and Quality Guidelines for Caregiver Assessment. We also looked at Family Caregiver Alliance Toolkit for caregiver assessment. I looked at other state assessment resources, mainly Minnesota, Washington, and Maine. We also looked at the Administration on Aging National Family Caregiver Support Program technical assistance resources. Evidence-based caregiver interventions, like those available at the Rosalind Carter Institute for Caregiving, and university caregiver research studies. T-Care, developed by the University of Wisconsin, and Reach 2 intervention developed at the University of Alabama. In addition to that, we looked at some caregiver stress and burden assessments, the American Medical Association's caregiver self-assessment, the Modified Caregiver Strain Index, and the ZERIT caregiver stress interview. The last thing we looked at were caregiver risk assessment tools, from the Reach 2 intervention, and also a caregiver risk screen. All of these tools were carefully reviewed. Next slide. And this review, keep in mind that this review was under the umbrella and was colored by, again, the requirements of Senate Bill 271. We also looked really closely at the implementation issues and also kept in mind time frame, the realities of the intake process, who were the staff that were going to be actually using the tool, and what kinds of training did they need, what was our time frame for implementation and development, and also statewide use. We also looked at cultural competencies and kept in mind disease-specific related information that we thought might be required. So we started with that overarching purpose and focus. And then the review of all the tools focused on the common elements present across the assessments, such as profile information, demographic commonalities, relationship, stress, and task information. We highlighted questions that address the Senate Bill 271 requirements, such as skill development, needs for information and education, and also impact on employment. We also reviewed common caregiver identification questions, demographic information, distance, was it a long-distance caregiver, and relationships again. We identified elements addressing employed caregivers and their issues, and reviewed the stress and burden measurement tools, the types of questions that were asked, the references that were made, and the scoring mechanisms for these tools. Next slide, please. The tools were revised then. Once we reviewed and came up with a draft of the tool, we got together as a work group for weekly meetings from September to December 2009. These meetings were very intense, very well attended. We had a committed group of folks involved in going question by question, reviewing each question and revising each element as necessary. It was highly labor intensive, extremely thought-provoking, and many of us had been in the business of serving caregivers for a long time, but we learned something new every time we met. We reviewed the tools and revised the tools for clarity. Did the questions really get at the information we wanted? For content, for language, not just culturally specific language, but also simple language, trying to avoid jargon where at all possible. For format, flow, did the questions make sense? Did the order make sense? Were the assessor and the intake individuals able to understand the questions? We reviewed the processes. How long did it take? What type of script needed to be developed for the assessor? And we also looked at the data analysis. Did we include all of the data elements that were required by Senate Bill 271, and also maybe some additional data elements that gave us information that we wanted? And lastly, we involved the stakeholder groups for responses to the final draft and the initial pilot. That was a very important step. Next slide. Of course, this labor-intensive work group meeting process was not without its challenges. Next slide, please. The first being the definition of informal caregivers, paid versus not paid. We have some informal caregivers in Texas that are able to receive payment for certain elements of their care. So we had to really be specific about our definition of informal caregiver. Again, language considerations, keeping it simple, making sure the process worked and the assessment worked for both English and Spanish-speaking populations. Time constraints. This was something that we really focused on in terms of implementation issues. Did we have the personnel, and did the personnel have the appropriate training to understand how to implement both the questionnaire and the assessment. Did we identify the caregivers correctly? How would we identify who was the primary caregiver? What if somebody had multiple caregivers? That was a challenging question that kept coming up. We also had a concern about the care recipient may be the one on the phone, the person on the phone who identifies the caregiver. Did the care recipient understand what we meant when we talked about caregiver? And who would that person be? There are some agencies in Texas who call their paid workers caregivers. This might be confusing. And the last challenge was that we could not include, given our time constraints and our reporting requirements and the requirements of Senate Bill 271, we were not able to include more detailed risk assessment elements in these two products and these two tools. The AAA partners had wanted that, and we encouraged them to continue to provide that type of risk assessment in addition to the tools that we provided. Next slide. Next, in summary, let me say that we were successful and we did implement the Caregiver Status Questionnaire on August 2nd, 2010. Community Service Regional staff were charged with that. And again, remind you that this survey was designed for individuals entering the agency's intake system for long-term services and supports, and that the Caregiver Status Questionnaire functions as an identification tool to identify the caregivers and make referrals to the appropriate resources for these caregivers, and to develop a statewide profile. What do Texas caregivers look like, and who are they, and what are their needs? Next slide, please. The Caregiver Assessment Questionnaire was implemented on August 9th by the Area Agencies on Aging and was completed for all caregivers receiving care coordination through the Older Americans Act Title III-E program. The assessment, to remind you, goes a step beyond the Caregiver Status Questionnaire by serving as a tool to identify more detailed, more in-depth needs for services, for education and training, and also for support received through the AAAs. Next up is Lisa Akers-Owen.
Thank you, Patricia. Next, I'm going to discuss the implementation of the Caregiver Status Questionnaire by the DADS Community Services intake staff at the local DADS offices. Next slide, please. The purpose of the Caregiver Status Questionnaire, or CSQ, is to collect data on informal caregivers. This additional caregiver data helps to ensure individuals are appropriately referred to other resources, including the Area Agencies on Aging. Ideally, the CSQ is completed at the time of the intake contact. The CSQ gathers data including caregiver demographics, caregiver profile data, caregiver stress levels, caregiver employment status, and the effect of caregiving on his or her employment. I'll go into a little more detail about the particular questions a little later in the presentation. Next slide, please. Community Services Regional Intake staff provide information about DADS services to callers seeking assistance from DADS. They determine what services are being requested by the caller. They ask if a caregiver is present, and if so, they complete the Caregiver Status Questionnaire, and they make referrals to the appropriate resources, including referring caregivers to the AAAs for caregiver resources. Next slide. The CSQ process is a part of the entire intake process when individuals call in requesting DADS services. During the intake process, intake staff ask if there is an unpaid caregiver who helps the individual and asks if he may speak to him or her. They ask for caregiver contact information for follow-up with the caregiver if the caregiver is not available. If the caregiver is available, they explain the purpose of the CSQ to the caregiver, and they read the CSQ script to set the stage for responding to the questionnaire. Next slide, please. Next slide. Okay. Part of the script includes providing the caregiver with the reason for the survey. Using the following opening statement that you see on the screen, intake staff explain that they understand the difficulty in balancing the demands of everyday life with additional caregiving activities. They go on to explain how the care being provided is invaluable, and they discuss how the information will be used to improve current services and develop additional resources and supports for caregivers. Next slide. Okay. The next few slides that you're going to see are actual screenshots of the caregiver status questionnaire used by the intake staff. I'm not going to read all of the information on the screens, but I do want to call your attention to some of the particular fields. Up at the right-hand corner, you'll see a field that says Caregiver declined to answer. We thought it was important to capture the number of caregivers who declined to participate in the survey. A little further down in that screen, you'll see where we ask about the caregiver's relationship to the care recipient. And then at the very bottom, we ask about the distance to the care recipient's home. So how far does that caregiver have to travel to provide that care to the care recipient? Next screen, please. This screen is the CSQ Caregiver Profile screen. About halfway down the screen, you'll see where we ask how long the individual has been providing care to the care recipient and how often they provide that care. Next screen, please. This screen captures the effect of caregiving on the caregiver's employment. This is very important information. The first question we ask on this screen is whether or not the caregiver is employed, full-time, part-time, or not employed at all. We ask about the effects of caregiving on that individual's employment. You can see down at the bottom of the screen where we ask pretty detailed information about how caregiving is affecting that individual's employment if they're employed. We ask the intake staff to sort of just review some of these, not read them off each one, but review some of them just to give the caller an idea of the types of effects that caregiving could have on employment, such as effects on their schedule. Did they have to change their work schedule to provide care to the care recipient? Has it affected their pay? Have they missed a promotional opportunity, for example? Have they had to take frequent leave from their job? Has it affected their relationships or causing tension or problems with coworkers? And then finally, we ask if it's affected their performance at work and how it's affected their performance at work. Next screen, please. On this screen, we ask if the caregiver has a chronic health condition, whether it has affected his ability to care for the care recipient. If it has, let's see, I'm sorry, I got lost. We ask how that health condition has affected their ability to care for the recipient. We also ask if the caregiver finds caregiving to be stressful, and if so, how they would rate their stress level. Next screen, please. Finally, we provided the intake worker with the criteria for referring the caregiver to the AAA. And you'll see the criteria there on the screen. We close by thanking the caregiver for taking the time to respond to our survey. We explain that the information they've provided is going to be very useful in improving current services and developing additional resources and supports for caregivers throughout the state. Next slide, please. We also experienced some challenges of implementing the CSQ at the local office. Next slide, please. Next slide. Okay. I'm going to be talking about a few of those challenges of implementing the CSQ at the local regional offices. One of those challenges was overcoming fears from the intake staff who would be asking these questions relating to the amount of time that it would take to complete the intake, in addition to what the questions that they normally ask a caller. They would have to add these questions, and so their call times would take longer, and they would take fewer referrals. Intake staff ask race and ethnicity questions. Caregivers are sometimes reluctant to provide information out of fear some responses could affect eligibility. We explained to the intake staff that they should assure the caller that their responses would not affect eligibility, that the CSQ is a separate process from the assessment for eligibility. And of course, there were no funds appropriate implementation of CSQ. We couldn't add staff to ask these questions or lines to our call center queues. And finally, reporting. It's important to have IT involved when developing questions and responses so that those questions and responses are conducive for inclusion in a report. You should request reports early in the process and refine them as we go along. And recognize that analysis of the data is going to take some time. Next slide, please. Next, I'll be talking about some of the successes we experienced in implementing the CSQ. There was an increased staff awareness of caregiver issues and concerns. We heard from the intake staff that they didn't realize all of the issues surrounding caregiving. This data is going to be valuable in identifying and further developing resources that are tailored to the needs of caregivers, which was another success. We had anecdotal evidence of increased referrals to the AAAs as a result of the survey. And intake staff report that caregivers are very much appreciative of someone listening to their concerns. Next slide, please. As a reminder, the part that I just talked about was caregiver status questionnaire that is administered at the DAD's local offices when individuals call to request community services. Next, Sue Fielder will discuss the Area Agency on Aging implementation of the Caregiver Assessment Questionnaire.
Thank you, Lisa. Next slide, please. The State Unit on Aging, DADS, implemented the Caregiver Assessment Questionnaire through Texas's 28 area agencies on aging, most of which are located in councils of governments. AAA are responsible for administering a broad array of direct services to persons aged 60 and over, their families, and their caregivers. As a result of amendments to the Older Americans Act in the year 2000, the National Family Caregiver Support Program was enacted to allow area agencies on aging to expand services to caregivers, including those under the age of 60. Along with information services and education and training, area agencies in Texas provide caregiver support coordination or case management to caregivers. When an area agency on aging provides comprehensive caregiver support coordination, it is at that time they are required to administer the Caregiver Assessment Questionnaire, or the CAQ. Next slide, please. The Caregiver Assessment Questionnaire is more expansive than the Status Questionnaire. The CAQ is completed for caregivers who are identified to have more complex issues and require a higher level of coordination of services. As a standardized tool, it is designed to consistently evaluate the needs of caregivers served by AAAs across the state. The assessment includes the caregiver profile data and caregiver employment data reflected in the Caregiver Status Questionnaire. The next 4 slides will reflect the sections for caregiver needs assessment, caregiver skills and training assessment, caregiver stress interview, which is expanded, and the caregiver risk assessment. Let's take a look. Next slide. The caregiver needs section seeks to identify the level of awareness caregivers have of support services in Texas. Note, it includes a question about why a caregiver is seeking help now if the caregiver had not received help before. The results of these questions may help us identify effective ways to get the word out to let caregivers know help is available. We may also be able to see gaps. Where might caregivers be located who do not know of services? An example would be, what are employers doing to support their employees when caregiver issues arise? We may also be better able to determine what triggers a person to seek help, which could provide direction in how we can best reach caregivers at the appropriate time. Questions have also been included to identify potential barriers to accepting help when the need for caring for another person arises, as well as to determine how the caregiver feels about receiving help. Next slide. This section assesses what types of activities caregivers must perform to support the individual in the community and identifies the level of knowledge the caregiver has of the recipient's chronic disease or condition resulting in the need for help. It is also helpful in determining the level of skill of the caregiver in relation to the types of help they provide. Do they know about proper lifting techniques to avoid injuring themselves? Do they have resources in times of stress? Can they recognize the signs of disease progression which might indicate a doctor's visit is needed? Have they developed coping mechanisms for barriers when life could be made easier by a home modification? The assessment then focuses on what assistance or training the caregiver may need to support them in their role. This is extremely useful in the care planning process for the individual. It is also going to help AAAs identify trends in their region so they can plan training events to meet those identified needs. Next, please. It is well known the caregiver role can create minor to significant stress. This segment of the assessment has raised a considerable amount of discussion among the AAAs and the state. Questions 38, 40, and 41 appear to cause the greatest level of discomfort for the AAA staff to ask. And they have reported these questions seem to make the caregiver somewhat guarded, as the questions can seem to be a little invasive. While some have suggested the entire section be removed, on the other hand, some have suggested simply rewording the questions now that they've had an opportunity to administer the assessment for a while. Those AAAs offering alternatives seem to be the most likely to find the entire assessment of value. The state feels assessing the level of stress and how caregivers cope with that stress is a vital component of this assessment. Next. The caregiver priority status section was added to the assessment at the request of our area agencies on aging. Once the assessment is complete, the interviewer can select among the different categories. These categories include the priorities established under the Older Americans Act, and using this assessment function was an easy way to immediately identify caregivers who meet the Act's targeting parameters. Completing this part of the assessment is optional. However, it is available to the AAAs as we witness the tremendous growth of the older population during a time of economic uncertainty. Next. What were the challenges? Next, please. As is true for any new initiative, there were challenges to overcome. Area agencies on aging were resistant to adding yet another responsibility to their staff's workload. Others expressed concern about certain questions, as I mentioned previously. During the implementation of the assessment, the state was rolling out a new client management system and converting data from 4 legacy systems to 1 state system. The data conversion occurred while the state was holding classroom training in Austin for the new system for approximately 500 users. Coupled with there being no funds appropriated by the legislature to launch the Caregiver project, the state initiated a staff hiring freeze. Also, the availability of staff at the state level to fully help the area agencies on aging adjust to the newly implemented system, as well as being able to provide the support needed to launch the Caregiver assessment, proved to be one of the greatest barriers to a smooth launch of the tool. Next. Let's talk about a few implementation highlights. The challenges we faced also presented opportunities for positive outcomes for the State Unit on Aging. When we implemented the client management system concurrently with the Caregiver assessment questionnaire, we had the chance to use the data input capability of our system for collecting this data. Area agencies on aging can use the system, one system, to directly enter assessment responses for each caregiver while entering other reporting data required. We avoided having to build a separate method of compiling the data or entering the assessment responses into a different system. In addition, our system includes a module allowing us to build ad hoc queries and permitting us to generate reports for basic statistics, as well as correlations and cross-tabulations. Next, please. So with our system, we're going to look at just a few of the data highlights that we are seeing so far. Next, please. Our ability to generate reports directly from the system is extremely useful, and it allows us to monitor the progress and success of area agencies in using the assessment. In July, the state found that of the 28 AAAs in Texas, there were still a few which had entered no assessments into the system. Each of these received a request for an explanation since all AAAs had gone live in our new client management system in mid-March. The AAAs maintaining assessments on paper were asked to have all assessments entered into the system by the end of this month. There were also AAAs, on the other hand, that received communication and recognition from us for having the greatest number of assessments entered in the system to date. Both methods appear to have been successful in encouraging the AAAs to get their data into the system, As you can see from this slide, the numbers increased 55% in a 9-week period. Next, please. So far, for the area agencies on aging, and this is for the CAQ, Caregiver Assessment Questionnaire, our data tells us 70% of caregivers assessed are female, with 30% being male. This is slightly higher. The percentage of males who are caregivers is slightly higher than the national average. The average age of those assessed is 63, but the average age ranges from 53 to 78 years across the state. When looking at the age ranges by AAA, our data shows caregivers in major metropolitan areas are typically younger than those in Texas's rural areas. Next. So who provides caregiving duties in Texas? Daughters and spouses represent the majority of caregivers in Texas at 34% and 33% respectively, followed by others at 13%, sons at 9%, other relatives at 6%, and significant others at 5%. It will be interesting when our state can further study our data, which will ultimately provide guidance in preparing a report to the Texas legislature and in establishing the direction Texas should take in serving our caregivers in future years. Next, please. As a part of the assessment, caregivers are asked about their concerns about receiving caregiver support. 12% indicated the care recipient is reluctant to accept outside help. 8% of the caregivers felt no one else could provide care as well as they can, and another 8% responded they do not trust service providers in the home. This is a multiple choice question, and caregivers can choose more than one answer. We have not yet determined how many answered yes to more than one question. So we'll have some thinking to do about this data and how we want to approach it and how we want to relate these concerns to the caregivers. Next, please. The data to date also tells us of the 1,696 respondents assessed, 6% reported taking leave frequently, 4% reported difficulty with concentration or focus at work, 4% perform or manage caregiver tasks at work, 3% have lost wages, and 3% have reported decreased productivity. This is also a multiple choice question, and it has received a low number of distinct responses so far. During the pilot and comment period for assessment implementation, the AAAs appeared to see this question as rather daunting because of the number of selections. Part of the education in using the assessment has been to remind AAAs lessons are prompts, and they are not required to read every potential answer to the caregiver. Because the response to the employment question has been low, we intend to look further into the data to see if there were a lot of refusals to answer or if the majority of the caregivers responding so far do not work. For the purposes of today's presentation, we simply wanted to provide some samples. Next. When responding to which tasks do you assist the care recipient with, the data tells us informal caregivers could truly be considered a lifeline for those they serve. 88% take care of homemaking chores. 85% monitor medicines and take care of physician visits. 83% give emotional support and provide transportation. 82% are responsible for supervision. 76% manage finances of the care recipient. And 73% are required to provide personal care. Next. The state has had an opportunity to talk about the assessment with AAA staff, and while there may have been resistance early in the process, it appears AAAs are finding value in using the tool. Some have reported the process has greatly assisted in care planning, but more importantly, it has helped caregivers identify their own needs, even the fact that they are indeed a caregiver. While caregivers are usually receptive to the questionnaire, some of the questions are tough to ask, especially when talking about the stress of being a caregiver. Even though it is a hurdle to complete an assessment with a care recipient present, often feelings are revealed that neither the caregiver nor the care recipient were aware of, and on occasion may be therapeutic. One observation made by a AAA was the assessment probably helps the caregiver to feel empowered to do more or something different with their loved one. Next, please. A few of the lessons learned. Should you embark on the same type of challenge in developing a statewide implementation, it's important that you market the tool as an opportunity, generate excitement about what the results could be, the data for future directions, and what the ultimate impact may be for the caregiver. Be sure those who use the assessment understand the purpose and value of each question. What seems obvious to you may not always be obvious to the user. Think about what a response could be for every question and how that response will be useful to the user and to the caregiver. For example, does a certain response indicate caregiver training is needed? Are other types of support needed? How is that resource accessed? The user needs to fully understand why a question is included. Communicate frequently with your stakeholders as well as the staff you are working with within your own agency. Be sure everyone understands what's next, what's expected or not, to be able to keep the project on track and consistent. It's critical. Have very clear, concise instructions for using the assessment so everyone understands when and how to use it. Build your method for reporting your data before your project begins. Know what you will need and who you will need in order to compile your data. Monitor the progress of the project. Being able to generate reports early in the process allows you to identify problems in the data collection system and to determine if expectations are being met. Then you can give a little nudge and feedback to keep the data flowing. Most of all, be sure to say thank you to everyone who helps in the project. At this time, for our wrap-up, I'm going to turn it over to Jeffrey Sider. Next slide, please.
Thank you, Sue. Next slide, please. Our next steps in this process for this initiative is to develop an inventory of respite services. Another bill that was passed during the 81st legislature was House Bill 802. In House Bill 802, as well as a grant that we received, is going to enable us to develop an inventory of respite services. DADS is creating this as a searchable database of respite care services in the state that are available through federal, state, and local resources. The inventory will include nonprofit, governmental, private, faith-based, and local community options for respite care. Searches will be available by target population, age, and/or disease-specific needs and geographic location. The next thing we need to do is we're going to develop a website. Take Time for Texas is a website that will feature numerous resources for both caregivers and providers of respite care. Resources will include self-assessments, tips, tools, health information, media toolkits, best practices, links, and news updates regarding statewide trainings and respite forums. The website is hopefully going to be up and available to our caregivers as well as providers in January of 2012. We also want to develop a letter to our caregivers that are surveyed through the CSQ. This letter will contain resource information as well as a link to the website where caregivers are able to go for more information of resources that are available within their geographic area. We're going to move forward on our data analysis and evaluation. We're working on that now. As you heard from Sue, we were able to provide you with some preliminary data on the CAQ. The CSQ data is much more complex because it was integrated within a system which currently was available to us for our intakes. Extracting that information into a usable analysis has been a challenge for us. We will continue to work toward the evaluation of that data and looking at what that summary analysis is going to bring to us when we compile our legislative report in December of 2012. The other thing we want to do is once we have the data before us and we know who our caregivers are and what their needs may be, we expect to be able to expand and develop new programs, but only when funding becomes available. We, as many other areas of the country, are in a financial crisis. And until funding becomes available either federally or through state legislation, our hands are pretty much tied with the programs that we currently have. In summary, the Caregiver Status Questionnaire, or the CSQ, and the Caregiver Assessment Questionnaire, the CAQ, are required by Senate Bill 271 to identify and collect information pertaining to the primary informal caregiver. Informal caregivers, as we've defined it, are those who are not receiving payment for those services. The CSQ, implemented in August of 2010, is applied as a telephone survey as new interested consumers enter the agency's automated intake system for our Community Care for the Aged and Disabled program, Community-Based Alternatives program, and In-Home and Family Support program. Other consumers who enter the intake process may also be surveyed on their caregiver needs. The Caregiver Assessment, or the CAQ, was implemented August 9th of 2010, is completed on all caregivers receiving care coordination or through caregiver support coordination through the Older Americans Act Title III-E program. The assessment goes a step beyond the purpose of the status questionnaire by serving as a tool to assist in identifying needs and appropriate services for caregivers accessing services through AAAs. That concludes our presentation. Sean, back to you.
Well, I want to give a big thank you to Jeffrey, Patricia, Lisa, and Sue. This was an excellent presentation. We've had a number of questions, so I will jump right in. The first question, we've had several questions about the link between answers on either one of the forms and the actual services received. One question was, we'll just leave it at that, the link between the answers on the forms and the actual services received.
This is Sue Fielder. In some of those discussions that I was referring to earlier with the area agencies on aging, planning the services and developing care plans, the AAAs have really found the caregiver assessment to really be enlightening and to really help them hone into exactly what caregiver, what are the greatest of the caregiver needs.
Okay, great, thank you. Our next question was focused on the caregivers who reported concerns about receiving help, and the person asked, if only 28% reported concerns about receiving help, then did 70% not report concerns? And is there a follow-up question about why the person did not seek help before?
In answer to the first part of the question, and this is Sue Fielder, the data that we've provided today really brought up a lot of questions and areas for which we need to search our data further. Because they are multiple choice, and as far as, if I'm recalling correctly, there is no follow-up question on the assessment for that.
Okay, thank you.
And I was going to say also that further analysis on the data is forthcoming, and what's been presented today is just to really give you just a very scratch of the surface of what we're starting to see.
And let me just add what Sue said. This is Jeffrey Sutter, and that is that whenever, and this is preliminary data, but whenever the information or a caregiver responds in a certain way, just because the questionnaire that the AAA staff may be at that time, they're not held totally to that. That's going to guide them into further assessments and identifying the needs. So it's going to bring forth much more questions of which the caregivers, coordinators should be able to make those notes to ask the caregiver further about those needs.
Okay, thank you. Jeffrey, our next question is about funding for the implementation and whether or not there was any funding included with the legislation. And a follow-up to that is, if there was not, how were you able to do it, and do you have any suggestions for other states?
Well, it's been very difficult because with Senate Bill 271, we received no appropriations. And in fact, the bill specifically stated that out of funds we were already receiving, this is what was expected. So it was a challenge. With Elisa alluded to in her presentation that we didn't have the ability to add any staff. And so basically the intake process for our community services programs is very, like at its max, very overburdened with the intake workers having every minute of their day taken up doing intakes, and adding on top of that the caregiver assessment was of concern. I think that when we looked at not only the questions and what Senate Bill 271 was telling us we needed to do, we also have to look at our resources and determine whether or not our resources would be able to, would be overtaxed by the amount of assessment or data that we were requiring. And so that's why some of the CSQ is actually limited much more limited than the caregiver assessment because of the time component. Like I say, we had no funding that was appropriated. However, some of the things that we are doing, we've been able to tie to other projects, such as House Bill 802, which is our lifespan respite care program. We're tapping into that for our resources because 271 instructed us to develop resources but without any funding. So we're using funds that were appropriated under House Bill 802 to assist us in the development of the website as well as the resource of the inventory resources through the Texas Respite Coordination Center. That then ties into some federal funds that we've received for that project as well. So that's the way that we're getting some of these activities funded.
And I'd like to add that it was just one of those fortunate timing things that when we were implementing the caregiver assessment at the AAAs, it just so happened that we had the resource of implementing our client intake system, so we were able to combine those. And while that was a challenge, it was an opportunity for us to, again, look at what resources were available and how can we combine those resources.
Okay, thank you. Our next question is about the percentage of caregivers that refuse to do the form, and then another question about how long it actually takes to conduct the assessment.
This is Sue Fielder. The area agencies on aging report that the assessment can take anywhere from 45 minutes to an hour. It just is dependent on the caregiver's situation and what type of other discussions arise by virtue of conducting the assessment. Refuse to answer we've not run those reports yet for the AAAs. Again, the data here today was simply just very, very preliminary, and it does make us think about, okay, now what do we need to look at? So that's a great question. Lisa's also going to respond to that.
I'm going to respond about this caregiver status questionnaire and implementation at the local regional offices at the intake level. You may have noticed I had some conspicuous omission of data in my presentation, and I talked about some of the challenges around reporting. It's important to, I think, have our IT folks on hand when we're developing the questions and to start requesting those reports early on in the game, and that was a lesson learned on my part. As far as the caregiver status questionnaire, it is a higher level set of questions that we're asking, not as detailed as the CAQ that's asked at the AAA. But even so, initially we provided our staff with a very, very detailed script of how we wanted those questions asked. You saw the opening, I think the screen with the opening line on how we explain what the purpose of the questionnaire and how the data is going to be used to benefit that caregiver. And I didn't share with you the remaining script for all of the questions. So we asked staff until they were used to asking those questions in a certain way to follow that script specifically. When the person gets it does take a little bit longer, and intake staff were reporting that the questionnaire took about 40 minutes using the script, in from 30 to 40 minutes. But once they got used to asking those questions in a particular way, we told them that they could discard the script and just go through and ask the questions. That did shorten it some to 15 to 20 minutes. We did unfortunately have data on how many refuse to answer the questions, but we hope to have that data soon.
Some anecdotal information that we also received is that this may be the first time that the caregiver has been approached sorts of questions. And so the time that it takes to complete a survey really will vary on the caregiver, because a lot of times you're tasked with having the caregiver back on focus and back to the question, because once you open up those sorts of questions for a caregiver, they really have so much needs and need for someone to hear what they're saying that they can go off on a tangent. And so that really is a key component of time that it takes to complete the survey. Now, where a AAA caregiver coordinator may have more time and the survey's longer indeed, they are indeed completing the survey, the questionnaire, the CAQ, for the purpose of assessing the caregiver's needs. Whereas for the CSQ, they're developing a profile for the caregiver, and based on the demands of the intake system, they have much less time available to them to be able to respond to the caregivers. Therefore, they have to keep the caregiver really on target in answering these questions in order to answer the next call that's in queue.
Exactly, Jeffrey.
Thank you. We just had another question about if there are any plans to translate the forms into languages other than English and Spanish.
Right now, no, we haven't found a need to translate them into other languages. The English and Spanish versions have proven to be satisfactory at this time. If indeed we did find that we needed to translate them, I think that we would find resources to be able to do that. Again, we have translation services here at the state that can ascend into the varying dialects of the Eastern dialects. That may be a little more difficult for us in order to locate those resources to help with translation. But as it is now, we have found that the English and the Spanish versions have been satisfactory.
Great. We had a question about the process of identifying the questions you wanted to include. Did you end up adding more or taking more out because you were getting too much information?
This is Patricia Bohr for that question. The simple answer is we probably, over the process of our question-by-question review, took more out than we wanted to. I mean, we would love to have an assessment that included many more questions and a lot more information to really drill down specific profiles of individual caregivers. But we always had that umbrella, as I said, of time, staff, and also time for the staff at the AAAs, and we had to be really respectful of that.
Okay, thank you. We had another question about how often a family caregiver would complete the CSQ or the CAQ.
Sue Fielder is going to give you that. What I'll talk to you a little bit about the CSQ. Is the one that's done in our community services regional offices during the Medicaid functional eligibility process. Because we're talking to them on the telephone and the vast volume of callers and consumers that we deal with and intake through that process, there's no way to eliminate duplicates. So a caregiver may be asked to complete a survey more than once, and we would not know that particularly. They would be tied to only one consumer, however. So therefore, if they were also the caregiver of another consumer who was entering one of our interest lists, they would be surveyed again potentially. That was totally up to the caregiver because the CSQ and the CAQ are both voluntary.
This is Lisa. Just to add a little bit to that, another one of our challenges is that many of our referrals come from hospitals or home health agencies or nursing facilities, and oftentimes that caller doesn't know who that caregiver is. So it becomes a little challenging to actually find the caregiver in some instances.
And this is Sue Fielder. In our system, because it is linked to an individual, we're able to see that a caregiver has completed the assessment already. And so, you know, again, we were just very, very fortunate to be able to incorporate that into the system that we were rolling out for the state.
Great, thank you. We had a question about the questions on the tools. Were they taken from existing tools, or did you come up with some of them, and who actually wrote the tool?
We're going to have Patricia Bordy respond.
This is Patricia Bordy. Yes, although I'd love to take credit for writing the tool myself. It was absolutely a team effort. I participated for a long time prior to this project. The state had been moving towards an assessment, especially specifically for the AAAs. So we had a long history of assessing, but nothing really consistent. So it was a team effort, and we even to the word for word, we reworded many of those questions many times. And we're not, I mean, it's not to say that these are the final tools. I would bet, as Sue Fielder indicated, with feedback from the AAAs and also the intake specialists, that we would move forward and continue to reword and add questions or remove questions as necessary.
And as those revisions occur, we have to keep in mind that the CSQ and the CAQ both offer the same set of questions, except the CAQ goes further. So any modification to a question in the CAQ would precipitate a revision to the CSQ tool as well.
And we would not want to revise any of the questions at this point until the entire project has been reviewed and evaluated so that we can maintain specific data. We do, although there isn't a specific script, or say the AAAs don't have to read every possible response, we do require that they ask the question the same way, and that is just for our future data analysis purposes. Thank you.
Okay. We had a question about any follow-up survey after they've done the questionnaire and they've said they needed services and they got services. Is there any sort of survey to see how their skills or their quality of life has improved?
For area agencies, they are required to always follow up on, you know, the quality of the services, you know, and how everything went, or other services needed, or they identified as a reassessment necessary. But we've not developed a formal tool for follow-up as far as this project's concerned.
Also on the caregiver assessment questionnaire, one of the tools that we use at the state is we do conduct an annual customer satisfaction survey, and so what we need to do is we need to look at that customer satisfaction survey now that we're 1 year into implementation and determine whether or not any additional questions need to be added to that annual survey to get the responses from our caregivers.
This is Lisa. Jeffrey talked about in next steps. At the regional intake level, we do plan to send out a follow-up letter after talking to the caregiver with additional local resources in their community, but that is in the future.
Great. Okay, this will be our second to last question. We had several questions about lifespan issues, so either grandparents caring for children or parents who are caring for a disabled adult. Would they interact at all with these forms?
Yes. For the area agencies on aging, if an individual is eligible for caregiver support services under the National Family Caregiver Support Program, and they have complex issues and will be receiving caregiver or care coordination, they are assessed. So caregivers of any age that are eligible under the Older Americans Act receive the assessment.
And this is Lisa. At the local regional level, callers are calling in for DADS community services from children's services all the way to individuals who are older. And so we would ask the question whether or not there's a caregiver available to talk to about the survey, regardless of the person or who's calling and which program they're calling for.
Okay, and we will close with a question if there were any lessons learned from either the pilot or just the overall project that you would like to share.
Well, I think one of our biggest lessons learned is that to get your information technology people and your data analysis people on board early. We were so focused, I think, on our tool development and collecting information that was required to us from Senate Bill 271 and looking at other national resources, how best to ask these questions, that we sort of overlooked the need of our information technology staff of being in those meetings with us to determine whether or not the questions that we were asking, how they would be implemented within existing systems, or in the case of our CAQ, what became a future system for our intake process. So that was a big lesson for us and that we're still struggling with today. As you can tell, we have preliminary data from the CAQ. Right now, we have not received any data that we can conduct any analysis on from the CSQ. Like I say, that's a huge, massive system that we made modifications to, and that was a long process to make those models. So once that information's pulled out, now how is it going to be looked at? We really would have benefited from having those people that are going to be responsible for analyzing that data with us to have been in those meetings early.
It seems to me, Jeffrey, just as you're saying, you know, the data that you derive is only as good as how the data goes into the system. And I'm finding, even with the preliminary data, it's raising a lot more questions. And having those IT professionals and data analysis professionals earlier in the process would have been tremendously helpful.
Yeah, I think that maybe some of the other lessons we learned had to do with the pilots, in that being that we had some areas that were ready to step up to the plate, and we're very happy to begin with the pilot. And we took those pilots, we allowed them to volunteer who would actually be in those pilot areas, and thinking that then gave us enough support within the community services regions and within the AAAs, not expecting that we may actually have some difficulty in some other areas that didn't participate, step up to the plate during the pilot project. So I think getting everybody on board early, and so that they understand the process and what's going to be expected and getting their buy-in is very, very important.
This is Lisa. I just wanted to add that I think that in terms of reporting, it's very important to have the IT staff available early on so that reports can begin being generated for the managers of those staff who are actually taking these calls. That way those managers can gauge whether or not those questions are being asked. So it goes back to how eager the regional staff and the staff of the AAAs are to participate and how on board they are, and that having that data available to those managers at the local level would have, I think, assisted in gauging how actively those intake staff and staff at the AAAs were participating.
Okay, any other?
No, that's it.
Okay. Well, I want to say a big thank you to Jeffrey, Patricia, Lisa, and Sue. It's clear that you put a lot of work into this project, and so did your coworkers. I also want to thank all of our participants for the great questions. As a reminder, the webinar and the PowerPoint slides will be archived on our website at www.caregiver.org later this week. You will also receive a follow-up email with a brief survey about the webinar. We would appreciate your feedback. Thank you to everyone for joining us, and this concludes our presentation.
On time.